And residency was done at one place?
A few hospitals in the
Okay.
Grand Rapids area. Yep.
But you were at, level 1
Yeah,
facilities
yep.
dealing with trauma and some other significant. So a lot of experience in those.
Yeah.
I would say,
there.
huge variety when you talk about a level 1 versus a level 3 or 4.
Right.
Gunshot wounds,
stabbings,
kind of almost every day.
Yeah, big car accidents
In those situations.
Mm-hmm.
So you get through that.
Yep.
And then you're like, where do I want to be when I grow up? Right. And so why Hillsdale? Why back here?
So I love this small town. I love being close to home. It's hard to overestimate the importance of being close to family.
Yeah.
But being able to get to know the people in the community really well, working at a small independent facility is amazing because I can have conversations with you like this instead of setting up 6 meetings.
Yeah, exactly.
Get to you.
You could text me and say, hey, let's go around this. Which he does. Well, and you come out of your mother's in healthcare, and one of our colleagues and friend, Dr. Schweitz, speaks very highly of your mother. I believe your mom does quality at a hospital. Is that what inspired? I mean, I don't want to put words in your mouth, but what inspired you to get in healthcare?
So she's a nurse. She was an OR nurse for my entire childhood. So I was really familiar, hearing stories about the OR and the
she's probably on call
stuff
a lot,
for
right?
that. But she got me linked up with some surgeons I was able to talk to, see what the lifestyle's like and what they actually get to do on a daily basis, which is pretty incredible.
So what was it like, your first experience? Not as a surgeon, not in training, not in med school, but you were an intern maybe, or maybe you just went and volunteered. Did you get to watch a surgery?
Yeah, when I was 16.
So is that what did it?
Yeah, I saw gallbladder surgery when I was 16.
Were you in love?
Yeah, hooked from there. I
said, 16 years old,
I'm gonna be a general
you're there,
surgeon. That's it.
You're in the room. Is this really happening?
Yeah.
And you watch that happen. And so at that point, is that when you realized general surgery, or when did that?
No, general surgery from 16 on.
Yeah. So you obviously had a lot of training, a lot of education, been in a lot of big places. You ended up rural because that's where your heart is, and you've done a great job for us. And as you reflect upon, decision making, because you could have gone anywhere. You could be in New Orleans right now and doing some really good food, doing surgery there. Was it a good move for you?
Yeah, definitely.
Yeah.
It's hard to beat the variety of cases that I'm able to do here, the variety of patient population. I don't have to just do one thing all day. I get to move around.
Would that get boring?
Yes,
I would think so. Some people like the niche or the specialty.
Right.
But so let's transition then. So, you're here. This is general surgery, truly means general surgery. You and I know what that means, but maybe our listener doesn't understand what it is actually you do, because you're doing some procedures in your office.
Yep.
You're doing obviously operations all the time at the hospital. You're seeing your patients, both pre and post-surgical. Talk to us about, first of all, define general surgery.
That's a very difficult question to do.
Yeah.
Especially concisely. But I don't do surgery on brains. I don't do surgery on bones. I don't do surgery on spines. And pretty much everything else falls into general surgery. We do head to toe skin surgeries in office or in OR. We treat skin cancers. We do thyroid surgery. We do breast surgery. Anything in the abdomen.
Everything in between. So I know, Dr. March has often talked about even doing toenail removals and ingrown toenails, in the office, and lumps, bumps that you remove in the office. What determines when you're going to do something in the office and when you're going to do something in the OR?
Yeah, a lot of it is going to be patient comfort. So how large the lesion is. If it's going to be more comfortable to get some sedation, then it's usually a little bit better at the hospital. Sometimes patients don't want to be awake for what's being done. In which
knock me out.
That's no problem. We can take care of that. But a lot of patients are like, oh no, we'll just take care of it here, and that's no problem. So a lot of it comes down to patient preference. But we have pretty much any equipment that we need to do any of those skin things in office, no problem.
And insurance also plays a role in this as well, right?
Yeah.
I mean, certain things that, I mean, you're
insurance
restricted
plays a role
to.
In everything.
They do. Every day of our lives.
And that's, part of that. They come in for maybe what seems like a simple skin thing, but we still need insurance
You
approval.
do.
So we got to have them come back on a different day to do the procedure. But
generally speaking, insurance companies like to keep things in the office, cheaper cost point. Obviously there's not the expense of having anesthesia and all of those things.
Right.
What is the most common in the last 2 years that you've done in the office procedure?
Probably like a skin cyst or lipoma, which would be like a little fatty tumor.
Okay. So like that one television program, like
Dr. Pimple Popper.
Yeah,
we do a lot of that.
Do you talk like that and say, oh, this looks like gravy or things like that? Hopefully not. So you have those type of procedures, you sew them up, they go back to their normal lives. Life's good. So let's talk to you about what would constitute taking it to the hospital. What type of procedures, and give us a couple examples of what you most commonly have been dealing with.
Sure. Probably the most common procedures that I see that end up needing surgery at the hospital be hernia surgery, so belly button hernia or groin hernia, gallbladder is probably the other big one that we see. There's a ton in between there.
Everything in between. Someone comes with an appendix ruptured. And
and the stuff we see in the hospital
that come out.
Appendix or bowel obstructions. Colon cancers, things like that.
Typically, you're going to see those as emergent or urgent, right? That's how you find out about those.
Yes. Those are you show up to the ER with pain and you're having surgery that night.
Because gallbladders, gallstone obstruction, that sometimes predicates, got to do it now. And you're moving quickly on that. Some can be elective, right? I mean, people live with stones, right?
20% of Americans have gallstones, and I have gallstones.
Did you know you have it?
No, we were just practicing ultrasound on each other one day, and
you're like, wow, there it is.
But
you're functioning, and you
don't have any pain, so there's no need to take it out. But sometimes just those vague symptoms of nausea, or I do have a little bit of pain up here, can warrant intervention.
Right. So a lot is changing in your field. Obviously, gastric bypass is changing a little bit with some new procedures and even some new drugs that are impacting it. Can you talk to us a little bit about why would someone choose to have gastric bypass and or any type of intervention surgically versus, let's say, maybe using some long-term medications?
Those the long-term GLP-1 drugs are amazing advance in medication and the treatment of obesity. Obesity is a chronic disease, and it should be treated just like diabetes or hypertension, and those require lifelong medication. So this is similar. This is a lifelong medication. We do have surgeries that can treat it. The sleeve gastrectomy that we do here can have equivalent or better outcomes for most patients. It's just whether you want to take that step into doing surgery. And sometimes those drugs are great. We offer them in our clinic as part of our medical weight loss program. Patients can come in, we can trial them on that drug. It does simulate some of the feelings that you'd have after surgery of the early fullness, and then also getting you to see that you can lose the weight, which can be a big motivator for patients. And then there are side effects, and sometimes patients don't like how they feel on them, in which case then we can always offer surgery down the line. Sometimes even after surgery, 2, 3, 4 years down the line, patients start to gain a little bit of weight back, and in which case those drugs can be added on at that time too.
You talk about a lifestyle and a program.
Yes. So the surgery that we do is, again, the gastric sleeve, a sleeve gastrectomy. That is, it's a big deal surgery. Your life's changed forever as soon as you have that surgery. So we want to make sure that you have some commitment and understanding to what that's like, both us and the insurance companies. So it's a minimum of 6 months of seeing us every month, doing weight checks and making sure that you're committed to losing some weight up front, which is usually 10% of your excess weight. So whatever your weight is now to where your ideal body weight is based on your height and age, then we need to lose 10% of that extra.
So let me just ask you this question because it's often posed. What happens if they don't meet that criteria?
Then there's a good chance that they won't get approved for surgery.
And therefore, the insurance company says you do not meet the qualifications, right?
Yes.
So I don't want to sound like morbid here or anything, but will someone say, well, then I need to put on 15 pounds?
Oh, before coming to see us?
I mean, are there those, do they know what those thresholds are? Or do you get told that at time of intake?
Yes. So we have a huge packet that if you call our office or you get referred to us,
they're going to know if they don't qualify.
You're going to get a bunch of information about what the process is even before you meet with us.
Okay. Because self-pay on these type of surgeries is astronomical.
Right.
I mean, there are several places that you can fly out of, states or even
Tijuana.
country. and people usually die, certainly have major setbacks. But at the end of the day, these are expensive procedures if you're going to try to pay out of pocket.
Sure.
So there is a medical condition that requires it, a medical verification.
Right.
That justification, let me rephrase that allows for the insurance to certify for that individual to have the procedure. However, the insurance company, you have to go through some hoops, right? It's not just guaranteed you can do it tomorrow.
Correct. Yeah. So that's where that 6-month period.
So 6 months
at minimum.
Okay.
And our average is probably about 7 or 8 months.
So for 7 or 8 months, you're holding me at bay.
Yes.
I have to show progress.
Yes.
What type of progress?
So that's that weight loss, coming to your appointment every single month without skipping, because we need to document that consistency that you're willing to come see us, because you're going to keep coming to see us after your surgery too, to make sure that things are still going well. And then in that time frame, again, that's where some of those drugs can come through. It's you've made the changes to your diet, you've met with the dietitian, and you've talked about food choices and meal choices. And now you've met with our physical therapist, and you're on an exercise program, and you're doing everything we tell you to do, and you're still not losing the weight. That's when some of those extra meds can help kick in to get you to the point where you're ready for surgery.
So, but even beyond that, there's a requirement for a psychological.
Correct. Yes.
Because weight loss, significant and dramatic weight loss, can alter a personality.
Right.
And that is something that you're very concerned about as a physician, because post-surgical, it's a new lifestyle at times.
Yeah.
So we do some counseling. We work with therapists that will work with an individual to A, make sure they're ready for counseling, and then B, how do we cope after this? Because going out and eating could look different. We all gather around the table, and we enjoy.
Oh yeah, it's a
nice
big social
meals.
component.
Yeah,
for sure.
And then that takes a different coping mechanism to deal with that. What am I going to do? So they qualify, they're ready to go, they complete the 7th month, whatever it is, 6, 7 months. Do you have people that fall out in between?
We do have some people that fall out. We have people that, for a number of reasons, we have people that decide they don't actually want the surgery, or they're having such success with just doing it on their own that they don't feel like they need it anymore.
But you give them the weight loss incentive through the program that you're working on.
Right.
So with that, opportunities for individuals, they make an appointment with you. Does it have to be a referral from a primary care?
A lot of that's dictated by insurance, but yeah, definitely if you're
talk to your primary.
If you're thinking about it, we're always happy to, even if you're just want some more information, come see us, because we can talk to you about it. I mean,
and there's only one method today that we're utilizing for this, correct?
Yep, the sleeve gastrectomy.
Talk to us about what are you doing?
Sure. So we're removing about 3/4 of the stomach. Your stomach's a big bag. We're turning it into a banana. So it restricts the amount of food that you can eat at a single meal. It also removes, your stomach is an amazing organ. It produces a lot of hormones. One hormone in particular is called ghrelin, that lives in part of the stomach that we take out. And that stimulates your brain to tell you that you're hungry. And so a lot of patients, the tendency to overeat is an addiction type trigger. Yeah. And so it removes that stimulus of, I want a snack because I'm bored.
Right. So then I have a lot of gremlins. Are gremlins they're called? Or what are they called?
Gremlins?
Sure. Okay. I got a lot of gremlins because I'm always hungry, man. But some of that desire to eat then is gone away.
Right. And you feel full very quickly after meals.
I would assume the feeling of being full is the reduction.
Right.
Is that true?
Yes.
Now, what happens if I overeat? Am I going to feel it?
Yeah. And you may throw up because your stomach's just not big enough to handle that. And over time, if you continue to overeat, you can stretch your stomach back out.
So it can go back to somewhat of an original size. So that you have to be careful. Are you monitoring post-surgical patients?
We see patients regularly for that first year, and then at least every year after, pretty much indefinitely, to make sure that they're still doing well. But if they're having issues, obviously, see more frequently.
No reversal.
Nope.
I mean, so once it's done, it's done.
And that's where that psychiatric component comes in, is having a really good understanding that you've had this organ your whole life, and it's gone now. So.
Yeah. But before we change subjects, just last question about that. The food intake obviously reduces. And what I understand, it's like, I've known people who've had the surgery who are drinking like baby pouches of, because and that's all they can take in.
Yeah, it's
so your quantity goes down,
smaller
right?
meals. Yeah,
More
it maybe a little more frequent, but overall we're looking for a calorie reduction.
Yeah.
That's the goal. So,
So that's an option. So if you're interested in listening today, and you are interested in changing your lifestyle, having an opportunity to have surgical intervention to help you, there is an option available for you right here at Hillsdale Hospital through our general surgery office. Counseling is available. That's all part of the process. They'll work with you. You'll get a packet. You will spend months before you actually can have the surgery. Then there's a qualification of your insurance to verify you can have the insurance, cover that. And if there is no coverage for insurance, there is individual pay is an option as well, but we see less and less of that because it's so costly. All right, let's transition to something else. Right now, your discipline is changing a little bit. We have general surgeons that are getting involved in plastic surgery, and that's always happened, right? Are you doing much plastic surgery type?
Not in the traditional, cosmetic sense.
Right.
I didn't have a lot of exposure to that because plastic surgery is pretty robust
It
in
is.
the Grand Rapids area.
Yeah. But types of things that someone can have done. Can we have breast reductions? Right, is an option for Hillsdale Hospital to be able to do.
Sure. Yep. We're happy to talk about
So
that.
you can do that. Usually, it can be medically qualified if there's a condition that requires that. In men as well, gynecomastia also is I don't know if you see much of that.
We do. Yep.
In that surgical intervention. And that's basically reduction.
Outpatient surgery, and it's quick and usually pretty painless.
So quick, painless. I understand the recovery for it, though. It's compression and a lot of that does. Do you find that gets insurance qualified, or is that more?
Yeah, especially for men.
Okay.
Yeah.
So it can get qualified for that. What does that procedure look like, just to give someone an idea?
It's an outpatient surgery. Small incision just right next to the nipple. Usually the scar hides pretty well. Just removing that excess tissue that's not supposed to be there and make things look back normal.
Yeah. And then sometimes that requires additional surgeries, though, for cosmetic lifts and things of that nature.
It can,
But that's outside of what you would be doing. You would be doing the removal. Okay. So there's that option that's available. And any type of, when we start talking about cosmetics, some people associate, skin tags.
Yeah.
And things of that nature.
Oh, yeah.
You do that in the office, right? Do you see a lot of that?
Oh, yeah.
All right. What do you do for skin tag removal?
Skin tag, numb it up and shave it off, basically.
That's what you're doing.
Yeah. And they barely scar. It's quick and painless. Usually do that in the same visit when you first see me. Yeah.
So wart removals.
Yep. Moles, if you've got a mole, even if you've had it for a while, it's starting to look a little bit different. It's always a good idea to get those checked out.
So mole discoloration, they should really make an appointment to see you.
Yeah.
Talk to your primary care first, because that's always important, right? But if you don't want to do that and just bypass primary care, there's an option.
Yeah. Any new skin lesion, honestly, because skin cancer is on the rise along with everything else. And I know it's hard to get into dermatologists. So
And then for that, do you send those out to pathology?
Yes.
So you're going to be able to tell them if there is any type of cancer.
Yeah. Skin tags, not so much, but
but for the moles.
Yeah.
Skin tags, those are, irritating at best, right?
Yes.
So that can be helpful. Now, do you find skin tags, are they covered under insurance?
I haven't had too many issues.
Really?
Yeah.
Really? That's interesting. So you heard it, A through Z, right? I mean, general surgery encompasses just about everything. What I want to talk about today before we close is, wow, we're involved in a major project right now. And the project is, all right, trauma designation.
Yes.
So what is it? Why do we need to worry about it at Hillsdale Hospital? Are we equipped to deal with traumas here at Hillsdale, I guess is the first question.
Sure.
And why do we have to go through an accreditation process? Would you explain this to our listeners?
Yeah. So trauma designation is a combination from the American College of Surgeons and the individual state level. There's levels 1 through 4, 1 being what you typically think of the university of hospitals that are involved in not only taking care of trauma patients, but doing research and advancement in trauma. Where level 4 is kind of at the other end of the spectrum, which is what we're attempting to complete here very soon. And that is knowing that we have the capability of seeing trauma patients in our ER, admitting some trauma patients, but really getting them the immediate care that they need in those first couple of crucial hours and getting them to the final destination that they need to be.
I mean, you have brain trauma and that The tertiary
Right.
center's got access to brain
Yeah,
surgeons
brain
and
surgery, complex
neurosurgeons
orthopedic
and
injuries
yeah,
and multiple systems. You think about the big car accidents, things
yeah,
like that. Those are really best equipped at a hospital that has a real
yeah.
trauma intensive care unit, which at a small place you're never going to
No.
have. But
A team approach with, just a team of probably 8 that
yeah,
are going at your bedside at a tertiary.
exactly. Yeah.
Yeah.
But we want to make sure that the patients that are coming to our ER, because a lot of patients are trauma patients are not necessarily coming by ambulance, or they're dropped
Getting
off
in
by
their
their
car.
friend.
Yeah, they're jumping in the car.
Right. So we want to make sure that our ER is doing the right things for
Yeah.
the patients as soon as they walk through the door, making sure that everything is done in a timely manner, and again, getting them wherever they need to go.
I had someone tell me a couple weeks ago, they're like, I know you guys do blood draws and stuff up at the hospital, but you don't do any of that, like neurosurgery or vascular surgery. I said, that's exactly what we do.
Yeah.
The old process, and the thought about the hospital just being a Band-Aid station or a place where you come to get your blood drawn, those days are gone. We have multidisciplinary approach to a lot of the care that we do. So when a hospitalist receives you as a patient, places you in med surg, CCU, you may be consulted with by a variety of team members who are coming in. If the patient requires surgical intervention, you're at the bedside. You're having conversations about urgent, emergent. This is something we need to address right now. So you see a lot of that. The very frustrating part is hearing individuals say, well, Hillsdale can't do that, or Hillsdale's not equipped to do it. Yeah. You've been everywhere, man. Are we equipped to do things here?
Yes, absolutely.
Yeah. And a wide variety of things.
Yeah.
Which is why you're
really surprising for a hospital this size, the number of resources that we have.
Yeah. I'm often told that when I tell people we have neurosurgery and vascular surgery and urology, like, what? Right. Your rule? Yeah. We have been able to pull it off. Pacemakers.
Yeah.
And that's another option, right? For you. So we're going to close on, it's on my list, 2 different things, pacemakers and PNEs. So let's talk about pacemakers.
Yep.
You're inserting pacemakers. You've been doing that now for a couple months.
Yep.
You went through the training. I believe Dr. March does those as well.
Yes.
But you both have experience in this now. You've done several, I hear, already. Talk to us about how that process works.
Yeah, a lot of these patients are, it's a new diagnosis in the hospital. They're coming in because they're lightheaded, dizzy, they get admitted, and while here, they find out that your heart's not working. There's several different conditions that warrant a pacemaker, but it's usually because the heartbeat is slower than it should be. And that's where the pacemaker comes in, is to regulate that heartbeat and speed it up to where it needs to be, so that your brain's still getting the blood that it's supposed to have.
Right.
So the pacemaker procedure is usually done in that setting. The patient's already here. We do it, monitor them overnight, and if everything looks great, they go home the next day.
So essentially, it's quick surgery.
Yes.
I mean, you're making the incision.
Yeah, the patients aren't even there. We just do sedation, so they're still breathing for themselves. It's.
And then within probably 28 hours, they are out the door. And what does that look like for reoccurrence? People are coming back in to get those checked, or they
have they're battery operated, so eventually the battery wears out and they'll have to get changed. But the technology's gotten really good, so it's usually about 10 years if everything's functioning correctly.
Is that right? So 10 years before they have any concern usually mechanically about that. And so if I need a pacemaker, I'm probably going to get a referral from my cardiologist, right?
Yes.
So talk to us about how the process works.
Yeah, so our great cardiologist here, Dr. Wusu, he's always in contact with us. So if he sees a patient in his office that he thinks needs a pacemaker, he'll call myself or Dr. March just to let us know and have that referral. Those are usually, we see them in our office beforehand just to talk a little bit about the procedure if it's not, such an emergency.
Right.
And then get you scheduled. It's a similar idea. You'll come in, we'll do the procedure, monitor you overnight, just to make sure that everything's working as it should, and get you home the next day.
Versus having to drive 50, 70, 90 miles, you can get it done right here at Hillsdale Hospital in your backyard. That is what is so amazing. The last item, PNEs.
Yes.
Talk about incontinence and what there's solutions available for some of the concerns that our community has.
So incontinence is tough because it's kind of a taboo subject. People don't want to talk about.
They don't want to talk about it.
But there are options. If you've gone through some physical therapy, especially if you've talked to your doctor about this already and you haven't really seen the results that you want from that, then there's an option of similar idea to a pacemaker. It helps with the muscle tone to keep you from leaking throughout the day, either bladder or bowel incontinence. And the bowel incontinence actually has great data for this device. The InterStim through Medtronic is what I've trained on, and that is it's a 2-stage procedure. So the both of them are outpatient. The first stage is kind of a trial. So we put a wire in through your butt towards the nerves in your sacrum and do a test, basically a trial run. It's non-committal because the wires can be removed pretty easily. And if everything's working how it should, then we go back in and replace those with the permanent leads and the pacemaker.
And they're very successful.
Yeah, they're great. I mean, and they're really fairly simple to use. You know, I was a little concerned about the patient interface, but with the company gives you a cell phone.
They do.
That links up with your device, so you can monitor its progress. You can monitor how it's working. And then when you come to office, we can tweak some of the settings if things aren't working great or it was working and now it's not. There's lots of
this is technology that I don't think a lot of our community members understand that we even have. But, you know, people are living with incontinence right now and they're not going out. They're not enjoying their family. They're not enjoying church. They're not going to the grocery store because they suffer from this, or they're, you know, embarrassed or just feel bad about it. But this is a solution. We have restored people's confidence and returned them back to doing things that they can do in their community.
I mean, it's amazing to hear some of the stories of patients that they weren't leaving their house. They had to
We've
plan.
heard that.
I can only go an hour. I can't
trips.
do that. It's
they know where
far.
all the rest stops are. It's but that can be all removed.
And you get used to it after a while if you've been living with this for 10, 20, 30 years. But
but there are solutions. So if you're listening today and you or someone you know is suffering from this, you don't have to suffer any longer. There are options available, and this is medically approved and insurance covered, and the procedure is outpatient. Plenty of opportunity for you to consult with your favorite general surgeon, and you can call their office. We'll get that number up on the screen here today. And we would just like to say thank you, Dr. Morgan. You have a tough job. You're on call almost now all the time. You know, between you and Dr. March, you're splitting call. It's like 50-50. It's a lot of work. It's hard work. You're seeing everything, every different variety and style, from traumas to, you know, to your skin tags in the office. You never complain. That's what I like about you. You always have a smile on your face, and you do a wonderful job for us. So thank you for your contribution. It means a great deal to Hillsdale Hospital. As I'm out in the community, I hear your name a lot now.
Good.
You know, shopping the other day, and I heard about Dr. Morgan, Dr. Morgan. So that's always good to hear, for the good, right? I mean, it's great. Everybody's excited.
As long as it's for good reasons.
It's always
I'm
good.
happy.
Always good reasons. I think it won't be anything but good reasons. But if you're listening today and you have any of those issues, concerns that you would like to address with the general surgeon, lumps, bumps, you have any type of skin tags, whether it is a desire of you, if you're saying, you know what, I just really want to talk to them about weight management and what options are available. Counseling is available, opportunities to look at it. Do you fit, you know, what is necessary to qualify for particular surgeries? Those can just be conversations right at the general surgery office, located at 3 Meadows here in Hillsdale, right in your backyard. You don't have to leave Hillsdale County in your backyard to get the services that you need. So we would encourage you to look for your primary care for some direction. And if you want to bypass them altogether because you know what's wrong with you and you just want to go right to the surgeon, you have that availability to do that as well. In most cases, there are insurance requirements in some cases that require a referral, but they'll certainly work with you on that. So please check the number that's going to be on the screen and to make that call if you want some services today from our amazing team at Hillsdale Surgical Group, and a great team that it is. I'm going to open the floor up for any questions that may exist. You have answered all of the questions.
Fantastic.
Wow, that's amazing. Well, the opportunity for you, the listener, is that, you know, not everybody can jump on live. In fact, Kirsten shared with me that we're averaging in some of our broadcast up to 12,000 views. So if you have a question post the live, put it on the post and ask the question. We will get you an answer in a relatively short order. We'll ask Dr. Morgan and or his colleague, Dr. March, to respond to that, and then we'll give you an answer. But please feel free to ask any tough question, any question that you want to be private. You can send a private message to us as well. We'd be more glad to talk with you. And really, we want to thank you for trusting and utilizing Hillsdale Hospital Surgical Services. Your trust in us is what creates this opportunity for a hospital to remain. Utilizing us when you have choices to go 40, 50, 60 miles, but to choose Hillsdale Hospital, Hillsdale first, makes us truly Hillsdale strong. We contribute back to our local economy. We're the second largest employer in the city of Hillsdale. None of that happens if our patients are not using us and trusting us to deliver this high level of care. So thank you for your trust. If you're looking to join a winning team, right here it is. We have plenty of jobs. I think there's 30 some posted right now. Plenty of opportunities for you to join an award-winning team. Oh, and speaking of award-winning, can I say it now? Because the embargo is lifted. Yes, USA News has named Hillsdale Hospital a top workplace in the United States of America. Isn't that awesome? We're going to have some celebration here, I think, today or tomorrow. I think tomorrow, maybe. And we're going to tell our staff, thank you very much. This comes as a result of a survey the staff takes. It's not just us buying the survey, but the staff actually tell the third party, do they like working here at Hillsdale Hospital? And what do you like most? And the results placed us among all of workforces in America, not just rural, but all the workforce in America as one of the top places to work. So I'm excited. If you're looking to work at this top place, go to our website, hillsdalehospital.com. Under the career tab, you'll find all the job openings. And like I said, I think there's several dozen. We'd love to have you be part of the team. And there's opportunity for you when you hire in. Entry-level position. There's opportunity for education and training. You can go and become a nurse if you want, a CRNA. We've done it before. Plenty of opportunity to move your professional career into a new era of your life. So please look at our website, hillsdalehospital.com, for job availability. For discussions like this, of course, every Wednesday we come to you live, but also you have a chance every week on our podcast, Rural Health Rising, on Thursdays. Wherever you get your podcast, download that. And the transition, am I allowed to talk about the transition, is actually occurring. In fact, for the very first time, it is my pleasure to announce live that there is a new podcast that will be replacing, even though you can still listen to the episodes of Rural Health Rising, Rural Health Today. And the focus is going to be on similar topics that we had with Rural Health Rising. We're going to be interviewing guests from across the country about the challenges, the victories, the greatness of rural health in our country and in the respective corners of this United States of America, asking individuals from Texas, individuals up to Wisconsin, how are you delivering healthcare? What are you experiencing and seeing in your environment? We're going to be talking to industry experts about healthcare. We're going to be talking to political leaders about healthcare, and that's all coming up very soon because there's some important legislation that the Congress is going to be looking at as it relates to Medicaid, and we need to hear your voice, and we need to encourage you to voice your concerns where there may be some harmful legislation. More to come with that in the future, but wherever you get your podcasts, you can subscribe to both Rural Health Rising and Rural Health Today. We'd love to have you listen in to us and become one of our super supporters. And then every week, every Friday, 92.1 WCSR, we have whatever the feature is on this program, we feature it on the radio. And then it also goes over to 102.5 on Buzz on Saturday for the same feature. So there's plenty of ways to connect with us, to stay with us up to date on what's happening in Hillsdale County as it relates to your healthcare needs. Thank you for choosing Hillsdale Hospital. When you choose Hillsdale Hospital, you are placing our community, the jobs, all as a top priority. And we believe in making sure that you have the best patient experience possible. So we would say, Hillsdale strong, Hillsdale first. Thanks for joining us today.